Muito obrigado, Tomás, pela abertura. Só queria dizer que os doentes da refrativa que não ficam ver 10 décimos normalmente acabam na consulta de retina. E isso é capaz de nos baixar um bocado a média do ganho visual. Mas isso. Ia chamar agora a nossa convidada estrangeira, a Dra.ª Rosa Dolz Marco, que veio de Valência, para nos apresentar o trabalho que tem feito na degenerescência macular da idade, nomeadamente na atrofia geográfica e coisas que ainda não sabemos. A Dra.ª Rosa Dolz Marco é uma notória especialista da retina médica, fez um estágio de um ano em Nova Iorque no VRM, com o Dr. Janus e o Dr. Bailey Freund, com os quais desenvolve em colaboração estreita muitos trabalhos de investigação. Dra. Rosa, é um prazer ter-la aqui, quando quiera. Muchas gracias.
Muito obrigada por me convidar. Thank you so much. I'm so glad to be here, and we are going to review some ideas on AMD. We are used to talk about drusen and pigmentary changes in AMD, and then talk about advanced forms as geographic atrophy and neovascularization. But we know that there are a lot of lesions in between, and it's not the same to have age-related hard drusen with a new classification we call aging. It's not the same to have soft drusen, especially if this is associated with drusenoid PED when they coalesce into bigger drusen, or calcified drusen, because these type of lesions, they are going to have a lot of risk for advanced forms of AMD. And of course, there is a third type of deposit, the subretinal drusenoid deposits, that are really on high risk for geographic atrophy and also for neovascularization, especially for type 3. And also they are related to age-related choroidal atrophy, as Dr. Spade described, and outer retinal atrophy. So it's not the same to have one lesion or the other. And also, we are talking about geographic atrophy, and this term was coined in 1972, and this is a descriptive term. So now with the multimodal imaging, are we using still geographic atrophy, or we have to use another more updated term? How are we going to call this type of lesion? Geographic atrophy, because it's associated with neovascularization, so it doesn't fit into the term of geographic atrophy. So that it's what we are going to review today, and of course we have to still learn a lot on this disease. Those are my financial disclosures, and part of this work is done with Dr. Freund in New York and Dr. Christine Curcio in Alabama. I have a grant, and I'm glad to work with them in a donor eye registry, and we correlate in vivo OCTs with ex vivo OCTs and ex vivo histology with eye-track histology, so it's a really exciting project. I have divided the talk in 3 different parts. One will be the mechanisms of atrophy, then the detection and measurement of atrophy, and then the characteristic OCT signatures that we can see in these kind of patients. So about the mechanism, some of the mechanisms have been already discussed in the discussion that on AMD before, at the beginning of the meeting. And we know that some of the atrophy related to AMD, it's going to be linked to the disease itself. So these patients are going to progress into atrophy over the years, and we cannot really manage all these atrophic lesions. But we can also detect patients with some lesions at high risk, especially not to treat because we don't have still any treatment, but to inform our patients and don't say, well, you can go home and everything is good, because they are going to have a great risk. So if we diagnose drusenoid PED, we know that a higher amount of patients, they are going to develop neovascularization or geographic atrophy. If we detect drusen with signs of calcification, we know it's an earlier sign of atrophy. Also, lesions acquired by telephone lesions are going to have a higher risk for neovascularization and atrophy, and the age-related choroidal atrophy itself, which is defined by 125 microns or less of choroidal thickness in the fovea. What about the neovascular complications? So we may have also atrophy related to complications in the neovascular part of the disease. So we may have some RP tears. We may have subretinal fibrosis, these type 2 lesions or mixed lesions 1 and 2 that develop a lot of geographic atrophy or atrophy. And also patients with hemorrhage that they are going to develop these focal areas of atrophy and this big area of hypoautofluorescence. And also it's really, really important, and this has already mentioned, to differentiate the type of the lesion and not classify by angiography, but classify by OCT. It will be really, really important, and we have a lot of prognostic value in this classification. And there is some doubt here. We don't know, and there has no proof to say that anti-VEGF therapy is related to GA progression. And I'm going to show this paper. It's really interesting to know that the type of lesion, it's going to be really linked to the risk to develop GA. So type 1 lesions are protective, and type 2 and type 3 have a high risk for development of atrophy in these cases. So it's important also to inform our patients, and it's going also to change our management and treatment and our approach. So I'm going to present this case. This is a type 1 lesion in the right eye of this 78-year-old female, and an atrophic AMD in the left eye. And if you see the changes over a 7-year period, we see that there is a lot of progression of atrophy, especially in the left eye, and also some kind of progression in the right eye, despite the fact that there are 48 anti-VEGF injections. So the type 1 neo here, it's going to be just in the center and outside the area of geographic atrophy. So probably type 1 neo is protective for GA. And this is the same patient. You will see the progression of geographic atrophy outside the area of neovascularization in the near-infrared reflectance in the right eye. But in the left eye, if we see the same progression, we are going to see that the progression of geographic atrophy, it's really fast. So I'm not saying it's not linked GA to injections, but there is, it's a really complex mechanism, and these patients have a lot of a multifactorial way to develop geographic atrophy. So we cannot really easily say that it's really linked to the injections. So, and what about detection and measurement? I'm sure how many people use autofluorescence to detect geographic atrophy? One there only? No, there are more people. So normally we use autofluorescence to detect geographic atrophy, but sometimes we don't have the possibility to have autofluorescence. So what can we do? So, and also we need dilation for these patients in order to take an image. And it's not really comfortable for patients to take every single day the autofluorescence. So another option is to have near-infrared reflectance. Normally it's next to OCT, if we are lucky enough to have a spectralis, and we have a lot of information here. So it's a way to have the progression of atrophy with a lot of more images compared to autofluorescence. And it has been also published that we can use near-infrared in order to really detect the foveal zone, because you know that due to the pigment, macular pigment, we have a block. So we have hypoautofluorescence in the fovea, as you see here, but we can evaluate here better with the near-infrared. So if we combine both methods, it's going to be really useful. But be careful, because we publish also that we have here an area of atrophy, no doubt that we have atrophy of the RPE, but depending on the choroidal thickness, the infrared reflectance is going to be hyper-reflective or iso-reflective. So it's going to be normally this way, but in some cases, if the choroid is thick enough, it's going to be iso-reflectant or even hyporeflectant. So be careful, because we can miss in this multifocal patient with multifocal GA, we can miss some lesions. And going back to the classical way to see geographic atrophy, we normally use color fundus, and also autofluorescence. But now we have OCT, and OCT has a lot of information on it. We see the lack of RPE as the choroidal hypertransmission, and this is a sign that the band of the RPE is missing. Okay, but we can also see that all these layers, the outer retinal layers, are missing. So how we call these? And how we call these kind of lesions? We have hypoautofluorescence here, but we have also a ring of hyperautofluorescence. There's no doubt that we have an area of atrophy of the RPE, but what's outside? So the OCT is really useful. We have magnification here. We see an area of loss of both the RPE and the outer retinal layers, and this corresponds to areas of hypoautofluorescence, but we can also see areas of loss of the outer retinal layers with preservation of the RPE, and this is outer retinal atrophy. So both types of lesions correspond to atrophic changes in the AMD, and autofluorescence, it's also informing about that, but OCT is really easy to detect these kind of lesions. And this was described by the CAM consensus. This is the classification atrophy meeting, and they have proposed these terms. So they call RPE and outer retinal atrophy when we have combined atrophy of both the RPE and the outer retina, and this is RORA. It will be complete when it measures more than 250 microns, and incomplete if we have a smaller lesion. And what about those kind of lesions with preservation of the RPE? Well, they have called them outer retinal atrophy, ORA. Okay, it's a little bit complicated, but it's it makes a lot of sense. RPE and outer retinal atrophy, RORA, or ORA, when you have only atrophy of the outer retinal layers and you have preservation of the RPE. And this is going to really be the way we are going to describe atrophic changes, especially when using OCT. And nowadays we are using OCT every day. So when we use geographic atrophy, when we are calling geographic atrophy those lesions with RPE and outer retinal atrophy, but in the absence of neovascularization, because this is the definition of geographic atrophy. And nascent GA will be the incomplete geographic atrophy or smaller lesions. And what about the rest of the patients? Because we have a lot of patients with neovascularization and atrophic changes. So we can use the term macular atrophy, and that will combine all the atrophic changes in these kind of patients with neovascularization. So the question is how we measure then, with all this new definition, how we measure atrophy. We can measure the choroidal hypertransmission, But we can also measure the subsidence of the OPL or the loss of the ELM. So what we use. In this case, for example, we have hypertransmission. It's quite clear, and we can easily define the area, but look at the RPE. It's not really correlated directly to the area of hypertransmission. And what about this case? So it's really difficult, at least to me, to really define a really defined area of hypertransmission. I can draw lines of hypertransmission, but not an area. So where is the atrophy and where not? And again, the RPE is not really corresponding to the area of hypertransmission. So what about the histology? How they measure atrophy? Well, they don't use the RPE, in fact, because the RPE is really dysmorphic in the border of the atrophy. They use this band. Does anybody knows what's this band? Here again. So here you have RPE, basal laminar deposits, and Brooks membrane. And then here we have outer segments of the photoreceptors. And there is a band here that we see every day in the OCT. This is the external limiting membrane. So this is called ELM descent, which is the curve that the ELM draw towards the Brooks membrane in the border of the atrophy. So this was described by Sarks long time ago, and this is the definition by histology of atrophy of the photoreceptors. And we are now using, with Dr. Curcio, this definition. You see the ELM here, and you see the ONL going down, and the subsidence, and the RPE. We are now using this ELM descent in the histology and the OCT in order to define the border of the atrophy. This is a work that was submitted to American Journal of Ophthalmology recently, and we see that the ELM descent is visible in the OCT. You have the red arrows drawing the ELM, and the descent is marked with this green asterisk. And also the correlation with eye tract histology. So we both see this ELM descent in the histology and the OCT, and it could be a marker for atrophy. What's the problem with hypertransmission? We found in this project, we found that only 22% of the borders that we analyzed correlated the ELM descent with the hypertransmission. So it's, the hypertransmission could be more variable, as I have shown, because the RPE gets really disrupted in the border, whereas the ELM descent, it's more, it's always located in the same location, and it's the border of the outer retinal atrophy. So another thing is that ELM is visible in OCT unless the quality is really not good, and the descent is visible. And also, we don't see, in these cases of RORA, of outer retinal atrophy and RPE atrophy, we don't see ELM in the area of atrophy. So we are proposing that the ELM descent may be useful in OCT as a marker of the border of atrophy. But a lot of to learn is still a lot of to learn, because we have still to know if this is really clinically relevant and we can measure all the patients with this new marker. And last but not least, we can detect some OCT signatures in patients with geographic atrophy. The first of them, it's going to be quite familiar now for you, because if you see here, you can see that there are some round lesions appearing here. And if we see the steps marked here, you see the ELM going curved and scrolling, and then forming these round lesions. This was described in OCT in 2009 by Dr. Freund as outer retinal tubulation, but in fact was first described in Histology by Dr. Curcio in 1996. And the characteristic of this lesion, it's a neurodegeneration, and normally it's located in the outer nuclear layer, and it's characteristic to have this hyperreflective band, which is really useful to recognize this type of lesion and differentiate this lesion from cysts. So this round lesion here is ORT, outer retinal tubulation, and this band corresponds to the ELM and the mitochondria. And why it's related to the ELM descent? Because we have seen that if we follow the ELM, we can have steps on the formation of outer retinal tubulation, and we have proposed these steps from flat to curved, and then reflected, and then scrolling. And why it's important? Because if we see the ELM scrolling, maybe we think it's a point of no return to have the formation of outer retinal atrophy. So it will be really important in patients that are going to have some gene therapy in choroideremia, or some therapy in cases when we will have in the future therapy for geographic atrophy. We also know that in cases with this ORT tubulation, we have also this kind of lesion. And for sure you know that this kind of lesion was described by Dr. Moniz in 2012. And he described this lesion as a hyporeflective wedge-shaped band. And this is only the optical properties of the Henle fiber layer at the edge of the atrophy. So it's not really a sign of fluid, it's just the position of the Henle fiber layers in the border of the atrophy. But it's important to differentiate this shape, this wedge shape, from this other wedge shape described by Dr. Kerkes. And this is completely different because it's not really a wedge shape, it's more a plateau. And it's over areas of geographic atrophy, and for sure you have seen a lot of cases of these. And in order to differentiate these two lesions, Dr. Freund and the group with Dr. Curcio have proposed the name plateau, because it's more descriptive, it's not a wedge. And the important thing here is that normally we have an origin of a drusenoid PED that is going to have progressive changes and collapse, and then the plateau is formed by the persistence of basal laminar deposits. And the important thing is to differentiate these kind of lesions from any neovascular sign. OCT is really clear here, and we don't see any sign of neovascularization in these cases. So these three lesions are really important because all three we don't have to treat. And they are all hyporeflective, and they simulate all fluid, but they are not exudative changes. And last, this is another case of neovascular AMD with an RPE tear and a lot of fibrosis. And you see these kind of lesions. Do you know what's this one? Well, this is a choroidal vessel, and what about this one? This is hyporeflective with this tail of hypertransmission. Have you seen these lesions? So this was described also by Dr. Kerkes in 2016, and they called these lesions choroidal caverns. They describe it in geographic atrophy, and the hypothesis was that this corresponds to non-perfused ghost vessels. And they don't mention, but they illustrate this tail of hypertransmission, that it's going to be really important. And we have different hypotheses, and this work has recently accepted for ophthalmology. So this is an 80-year-old male with geographic atrophy, and we see the infrared with all these hyperreflective lesions next to the choroidal vessels. And if we do an OCT, unfast OCT, a structural OCT, we see all these hyporeflective lesions around the choroidal vessels. And in the structural B scan, it's really characteristic to have a hyporeflectivity with a tail of hypertransmission. This is the unfast OCT again, and if we do an OCT-A, we don't see any flow inside. So we can easily differentiate these lesions from choroidal vessels. And also the distribution, it's really characteristic. They are round, not tubular, and they are next to the choroidal vessels. So we did a review of the literature of the lipids seen on OCT, and there are a lot of uses of OCT in cardiovascular diseases. And the lipids are seen hyperreflective when they are droplets, smaller than 5 microns, but they are seen hyporeflective when they are larger. So in this case, we have a larger lesion, about 50 microns. And we know that the choroidal vessels are going to absorb a lot of light compared to the lesions, these lesions that we think they are lipid, okay? And why they have this tail? Because the lipids don't absorb light compared to the choroidal vessels, and that's why a lot of light passes through the globule, and we have this hyper transmission. So anybody knows of lipids in the retina or the choroid? Anybody from surgery, maybe? We have seen these similar lesions when we use surgical, when we use silicone oil, and we have retained intraretinal silicone oil. And we have these hyporeflective lesions with tails of hypertransmission. But also, if we go back to 1966, Dr. Friedman described the globules in the choroid, lipid globules, in patients with normal retinas or in cases of AMD or diabetes. So Dr. Curcio was working on these globules, and she has described these globules in 42.3% of normal retinas and normal maculas, and they are located around the choroidal vessels, next to the choroidal vessels. And the main characteristics is located in the choroid mainly, but also in the sclera or even the subarachnoid space. And the most important characteristics is they are extracellular and they are extravascular. They are as large as choroidal vessels, and there's no sign of inflammation, so we think they are physiologic. So we think that caverns correspond to lipid globules, and this is an en-face view we have seen clinically, but this is an en-face view of the histology. You see the arteries and the veins in the choroid, and next to these vessels, we see the globules in the same distribution than the en-face OCT. So those were the lesions that I wanted to present. So in conclusion, the utility of the OCT in evaluating patients with AMD, it's of course, there's no doubt. The spectral domain OCT can show really cellular and subcellular details, and we have seen examples of these and correlation with histology. And we have to learn all these new terms in order to describe all these atrophic findings in cases of AMD. It's important to differentiate the type of deposit that we have, because this is going to change the prognosis in our patients, and especially if we have special lesions as drusenoid deposits, mineralized drusen, acquired vitelliform lesions, or age-related choroidal atrophy, and also detect some signs that may mimic intraretinal fluid, but they are not necessary to be treated because they are not related to the exudation. So thank you so much, and especially thanks to Dr. Christine Curcio and Dr. Freund for allowing me to work with them. Thank you so much. I don't know if you have any question or...
In Spanish?
I don't know. Go.
Okay. Congratulations por esta presentación, es muy buena, muy completa. Y son imágenes muy bonitas. Y está muy bien sistematizado. Todas las descripciones de los hallazgos o findings que tenemos en el OCT y que son nuevos, y creo que está presentado de una forma muy didáctica. Gracias.
Muchas gracias.
Una pregunta nada más, que es de la primera parte de la presentación, en que las RAP, las Type G y las Type 1 aparecen como asociadas pós-tratamento a un aumento o más propensas a tener Geographic Atrophy. La cuestión es si esto es porque estas lesiones de inicio ya están asociadas a atrofia o si es el tratamiento que produce la atrofia, porque la RAP ya tenemos más atrofia desde el inicio, ¿no? ¿Y cuál es la opinión que tienes sobre...?
I have to speak in English or Spanish or whatever you prefer.
Okay.
Well, I think I'm going to speak in English because I don't know if you all speak Spanish. So I think, well, type 1, I think it's protective. And type 2 and type 3, of course, because of the physiopathology of the lesion, they have already geographic atrophy at the beginning of the treatment. What I think is type 3 is especially related to multifocal areas of geographic atrophy, so I don't think all the atrophy is related to the lesion itself, because normally these cases have a lot of patches of atrophy. So I think it's mostly related to they have associated age-related choroidal atrophy. They have also associated subretinal drusenoid deposits. So their choroids are really in a bad shape. So I think it's mostly related to the physiopathology of AMD, but not to the intravitreal injections itself. But as Sarah has mentioned in the discussion, I will treat these patients more with a PRN approach, not with a treat and extend or monthly based protocol, because I don't have any proof that intravitreal injections are going to have GA, but in case of doubt, I prefer to treat in a proactive way, not in a reactive. In a reactive, not in a proactive way. And for the type 2, they have a lot of outer retinal and RPE atrophy, and the response is really good, but the prognosis is really bad because of these changes. But I think it's mostly related to the disease itself.
Thank you very much, Rosa. It was a pleasure.
Muito
I really
obrigada.
enjoyed your talk. I think this was the first time that I actually managed to stay awake while showing histology, which is brilliant. So the talk is really very good. Thank you. Thank you very much. Gracias.